This is Lauren Smith, student physical therapist at South College. Some surgical precautions and considerations that are relevant to this case are his sternal precautions due to his sternotomy, so we want to make sure that the patient doesn't lift his arms up over his head, out to the side, or behind his back. We have a safety consideration to place the gait belt above the chest tube when we mobilize the patient so that we're not at risk for ripping it out or pulling it out when we mobilize. And we would also want to assess for DVT and pulmonary embolism because of his recent surgery, so we want to ask about things like if he's having any calf pain. Simply the amount of lines present is a consideration for this case because he has a lot of lines that could be difficult to manage if we're not organized properly, and there are no contraindications to PT concerning this question. So any variations from his normal vital values, he has a slightly lower than normal respiratory rate of 11 out of the range of 12 to 20. So he may demonstrate shortness of breath during activity, and this may require frequent rest breaks and deep breathing exercises before continuing with our treatment and activity. His blood pressure is normal and of 100/78 and has been trending upward. But regardless of this, we should continuously monitor his blood pressure because he had a recent surgery and he had a loss of blood and is on pain medications, and all of this can cause him to have orthostatic hypotension. So we just want to make sure we continuously monitor blood pressure and take a symptoms-based approach by monitoring any lightheadedness or a change in pallor that the patient may have. The patient's lower blood pressure is still normal, but it's slightly lower than the average person, and we would expect this because of his recent surgery, and he was on anesthesia, his pain medications, and he could be dehydrated to not having fluid intake before his surgery. And he's also on a beta blocker, which can all lower blood pressure, but it's still trending upward like I said before, so we just need to keep monitoring it. And then the low respiratory rate that is trending down is expected because it can be a side effect of pain medications. It would be appropriate to treat this patient based on vital sign values and trends. Blood pressure is currently in the treatable range and will be continuously monitored in supine, sitting, and standing to watch for orthostatic hypotension. And as long as the patient does not drop to a blood pressure of 90/50, we will be able to proceed with physical therapy. And as long as he doesn't have the increase in his heart rate from 30 to 40 beats per minute when changing positions. This goes along with orthostatic hypotension. And then his SpO2 is currently at 98%, so his slightly lower than normal respiratory rate of 11 is acceptable because his O2 sats are so high. Concerning his lab values, his white blood cell count is higher than the normal range, while hemoglobin and hematocrit are lower than the normal values. High white blood cells may indicate that the physical therapy be started later in the afternoon because this is when the patient's energy levels will be at their highest. Low hemoglobin and hematocrit will limit oxygen carrying capacity, so the patient will present with fatigue and have low endurance. And this will require activity to be progressed slowly. His INR is at a 1.8 and is lower than the therapeutic range of 2.5 to 3.5 for prosthetic valve replacement, so this could put him at an increased risk for clotting. Low hematocrit and hemoglobin are expected due to blood loss from surgery and dehydration due to the patient not being able to eat or drink before surgery. His high white blood cell count is also expected due to the surgery and inflammation from the incisions. His INR of 1.8 is trending upward and expected because he was put on a blood thinner, which was warfarin. His INR of 1.8 is contraindicated because, like I said before, it was out of the therapeutic range for the prosthetic valve replacement. So we would want to hold physical therapy until we consult with the physician. And we want to monitor for symptoms such as dizziness, headache, pallor, and chest pain concerning the other lab values that were out of the normal range. But these lab values are not going to stop us from proceeding with physical therapy. Concerning the precautions and considerations for each line and tube present, the EKG lines can be removed from the monitor and attached to a portable telemetry monitor that can be inserted into the patient's hospital gown pocket for transportation. The blood pressure cuff on the left lower extremity can be removed and out of the way before the patient is mobilized to be more efficient with fewer lines. And because we already have an arterial line, so that's going to give us our blood pressure readings. We want to continuously monitor the placement of the pulse oximeter on the patient's finger and make sure that it never falls off during any kind of activity during treatment, because we want to monitor his O2 sats. And we just want to inform the patient to not have a lot of movement with the finger that the pulse oximeter is placed on, so that it will be dislodged, or put any weight through that finger. We always want to keep slack in the peripheral IV in the left brachial vein and ensure that the patient does not sit or step over it by keeping it to the side of them and the lines out of the way during all of the transfers. And the same goes for the right radial arterial line. So we just want to always keep slack in it and ensure that the patient is out of the way of it by not stepping on it or sitting on it. Concerning the chest tube on the seal, we just want to make sure we keep the water seal level and below the level of insertion of the chest tube. And for the catheter, we want to keep it below the level of the bladder when mobilizing the patient and drain any fluid from the tube into the bag before we mobilize the patient. And for the nasal cannula, we want to remove his oxygen from the wall and attach it to a portable oxygen tank to be moved along with the patient. And we want to always make sure the cannula is remaining in his nose so that he can breathe. No lines or tubes would preclude the patient from participating in physical therapy. All of them will be able to be mobilized along with the patient, either beside them or attached to their walker. I believe the blood pressure cuff on the left lower extremity will be appropriate to remove because, like I said before, the arterial line will already tell us the patient's blood pressure. Concerning assessments, I want to measure his orthostatic vitals because, like we mentioned, he could have orthostatic hypotension to being immobilized because of his anesthesia, pain medications, beta blocker, fluid loss from surgery, and possible dehydration. And we know orthostatic hypotension could cause the patient to faint on us during treatment. So because of this, BP, blood pressure, and heart rate need to be monitored. And if there's any drop in systolic pressure of 20 millimeters of mercury, drop in diastolic blood pressure of 10 millimeters of mercury, or increase in heart rate of 30 to 40 beats per minute, the treatment should be halted. And I also want to perform the short physical performance battery as an assessment because this will give us an overall assessment of the patient's balance, endurance, lower extremity strength, and gait speed. And the patient is low functioning, so this won't be too hard for him. And assessing all of these factors will just give us a good baseline measurement of his overall functional mobility and his level of fall risk. Thank you. Do you have any more questions before I begin?